Good afternoon. I'm Dr. Dale Bratzler. I'm the Chief Quality Officer here at OU Health and the university's Chief COVID Officer. I'm going to give you a brief overview where we're at with COVID-19 right now and talk about a few things that are in the medical news at the moment. Just a couple of points I do want to make is I don't want to insult anybody's intelligence. I know all of you keep track of the cases, so I won't spend a lot of time on that. I do want to highlight, though, that COVID has not gone away from Oklahoma at this point, even though I see a lot of things that are suggesting that we've improved a lot. So just to highlight, Oklahoma currently ranks 27th in the nation in terms of the daily new case count, 31 cases per 100,000 population. Just before I came up to do this briefing, I looked at our data from June 7th, and we were down to 3 cases per 100,000 population per day. So we're still at a tenfold higher rate of new cases per day right now than we were in that first week of June when cases got so low. So again, this isn't over yet. Again, if you look at the United States map, the states that are really getting hit hard right now are on the northern border with Canada, including Michigan, Wisconsin, Montana, Idaho, and of course West Virginia still has quite a few cases. If we look at cases that the CDC tracks on a weekly basis, Oklahoma currently ranks 25th in the nation at 216 new cases per 100,000 population per week. So again, those numbers are much better. Remember that at the peak at the end of August, we were in the top 10 nationwide. Now we're down in the high 20s of cases. So today, as of today, the State Health Department reported more than 1,200 new cases of COVID-19. We're at 629,000 cases, and another 72 deaths were reported today. One thing I did want to highlight today is look at the 7-day rolling average. I provided a graphic that shows that we really have plateaued. The number really has not changed in the past week. So it's gone up and down a bit, but we're at the same point today as we were on October 7th. The 7-day rolling average in new cases per day truly is plateaued right now. So again, COVID-19 has not left us. There are still a lot of people being infected in Oklahoma each day. Within the past week, Oklahoma County had the most cases, followed by Tulsa County. Pottawatomie County, interestingly, was third highest this particular week. And when we look at hospitalizations, yesterday the number was quite low, and I actually questioned whether all of the data had actually been reported. There were just under 800 people in the hospital today with COVID-19. About 249 of those people are in the ICU, which puts it about 32% of people that are in the ICU. And finally, I always update the CDC's community transmission map. Finally, we're starting to see a little color show up. We're not entirely red. Cimarron County and Grant County in Oklahoma have both fallen into the moderate category for community transmission, which is good. And I think if we see the case counts continue to come down, we'll see more counties that start to have colors other than red, which may allow us to open up some things or reduce recommendations for things like masks in some settings. So in general, cases are way down from what the peak was on August 30th, but they're not gone away, and we're still tenfold higher than we were in that first week of June. Just wanted to highlight a couple of things. The American Academy of Pediatrics reports on the number of kids that are infected with COVID. I wanted to highlight this because I think it's important as we start thinking about vaccines that are going to be available for kids between the ages of 5 and 11, assuming that the FDA and CDC make that recommendation. But in the past week of reporting from the American Academy of Pediatrics, there were almost 150,000 kids that were newly infected with COVID-19. 25% of all the new cases in the nation are in kids below the age of 18. So again, children are still at risk, and while they tend to have fewer complications of the disease, they do at times develop long-haul symptoms, and some do end up in the hospital. And then that goes along with a couple of studies that were published that I think some people may already be familiar with, and that's that the study that have shown that school policies on masking actually substantially reduce transmission of COVID amongst kids. So there are two different studies that were published, one from Arizona that showed that schools that did not have mask requirements had 3.5 times more cases of COVID-19 than school districts that did have mask requirements, and then a large nationwide study that showed that there was about a 50% reduction in COVID cases in counties where the school districts had mask requirements. So I know it's politically charged, but I also know that the data are very clear now, continue to grow, that masks are very effective at preventing the transmission of COVID-19, which brings me to a study that was just released yesterday, looking at a group of schools in Iowa, and they basically were looking at, excuse me, what they call the secondary attack rate. So if somebody is infected, what happens to the people around them? The secondary attack rate. And in this particular study, they demonstrated that if nobody was wearing a mask, the person who was infected or the people that were contacts around them, there was a 26% chance that somebody would test positive. However, if both parties were masked, the person who's infected and the people around them, that dropped to 12.5%. So again, more than a 50% reduction in the total number of secondary cases that occurred when somebody was infected with COVID-19. Again, more strong evidence that masks are very effective at reducing person-to-person transmission of COVID-19. But the other thing that was important from this particular study was that they highlighted that 12.5% of the direct contacts still got infected. And so they made the point that keeping quarantine policies in place when somebody's infected and somebody's a direct contact can actually reduce cases even further than just wearing masks. So again, pretty good data that both mask and quarantine policies do work to reduce the spread of COVID-19. I wanted to talk very briefly about some of the discussions about booster doses for the COVID vaccines. And I put in a slide in the handout that will be sent out that basically highlights that we shouldn't be surprised with the COVID vaccine that you're going to likely need a third dose or second dose if you got Johnson & Johnson. And I just highlighted that there are multiple vaccines that we've been using for many, many years, and they all require multiple doses. So in healthcare, I as a provider had to get hepatitis vaccine, and again, I got one dose, I got a second dose a month later, and then I had to wait 3 months to get my third dose. That's very common with multiple vaccines that we use. Childhood vaccines such as diphtheria or DTaP, diphtheria, tetanus, pertussis, Hib vaccine or Haemophilus influenza vaccine. Influenza you have to get annually. So nobody should be terribly surprised that with the development of the COVID vaccine, the 2 doses primed your system, but it's very likely that you'll need a booster to actually enhance protection. And so I think everybody's aware that we have authorization now to give a booster dose of Pfizer. Remember, with the first 2 doses of the Pfizer vaccine, you get 30 micrograms of the mRNA in each dose. You get it 3 weeks apart, and now a recommendation for a booster dose 6 months after the second dose in people who are at high risk or above the age of 65. And again, that's the third dose is a similar 30 microgram dose. Part of the controversy around Moderna, company Moderna has applied to the FDA to get emergency use authorization for a booster dose in the same categories of people that Pfizer's approved for. But remember, with the Moderna vaccine, the 2 doses you get 4 weeks apart are 100 microgram doses. And so Moderna has applied to FDA for emergency use authorization for a half dose booster at 50 micrograms per day. The Moderna vaccine seems to have persistently higher antibody levels than the Pfizer vaccine. And there are two reasons that are suggested. One is just simply the dose of the RNA that you get, which is substantially higher. But the second thing is the 4-week period between doses versus 3 weeks, which may enhance the immune response. So it's not absolutely clear why, but just recognize that if FDA approves, gives emergency use authorization for Moderna booster, it'll be with a 50 microgram dose, half the dose that you got in those first 2 shots. And then Johnson & Johnson has submitted their data to the CDC and to the FDA. And they basically have shown that if you get a booster dose 2 months after the first dose, you see a 4 to 6-fold increase in antibody levels. If you actually wait 6 months between the first dose and the second dose, you see a 12-fold increase in antibody levels. So all 3 vaccines have shown that if you give a booster dose, you can enhance the antibody response, which may lead to additional protection. Now I highlight this, and I put a slide that I've updated again, which is cumulative data for Oklahoma, but I highlight this for our students all the time. Age is the biggest predictor of complications of COVID-19. Absolutely, we know that certain medical conditions and underlying conditions put you at greater risk, but when you look, if you get to the age of 85, 20.7% in Oklahoma of those patients with a positive test have died, 1 in 5, and 31% of those people end up in the hospital. And so all age groups have had deaths, but the numbers are quite low in the younger age groups. It's part of the reason that the booster doses are being highly recommended, at least at this point, for people who are 65 and older, because they are the people who are likely to have complications of the disease. And if you look at the weekly epidemiologic report that the health department puts out each week, yesterday's data basically showed that fully vaccinated people who end up in the hospital, almost 95% of them are 50 years of age or older. 75% of them were 65 and older. So again, just fairly strong support for the need to get booster doses, particularly into the elderly, since they're at greatest risk of hospitalization and complications, including death from COVID-19. The last thing I put in the handout was an article that came out in one of the medical periodicals that I read routinely, and it talks about the new drug that Merck has sent to the FDA for potential approval, molnupiravir, which is an antiviral medication. It's a pill. So if you tested positive for COVID-19, you could take this pill, one pill twice a day for 5 days. And in the studies that Merck has reported, it resulted in a 50% reduction in the need for hospitalization or severe disease. That sounds very good. Similarly, we know that we have monoclonal antibodies. We can give them for post-exposure prophylaxis, or we can give monoclonal antibodies to somebody who's actually known to be infected, who has symptoms, particularly with risk factors for severe disease. And when we do that, they're very effective, 70 to 75% effective at preventing hospitalization. But the point of this article was, in the United States, for some reason, rather than being vaccinated, we're looking for the magic bullet of treating somebody when they get infected versus preventing the infection in the first place. And again, I just simply want to highlight vaccination of all people right now, 12 and over, is recommended to prevent the transmission of COVID-19. We know that the vaccines are very effective at preventing the complications of disease. If you get COVID, you have a substantial risk of getting long-haul symptoms, and again, if you're unvaccinated, you're 10-fold to 17-fold more likely to end up in the hospital with COVID-19. So those are some of the things that I've been watching this week, and I'm happy to answer any questions.
Okay, so this one just came through. Can you clarify your questioning of the most recent reported hospitalizations data and talk in any detail about those numbers, beyond those numbers, about what it's been like in the past week for providers in hospitals, especially ICUs and ERs?
Yeah, so I think across the state. So the reason I question the numbers is yesterday, as I recall, the state health department reported that there were 718 people in the hospital with COVID-19, and today it was 788 or so. I don't think we saw that many people get admitted to the hospital overnight. My suspicion is that yesterday's number represented some lack of reporting. Perhaps some hospitals didn't get all their data in. And we've seen that happen periodically, that the number seems to drop of hospitalizations and then the next day we go up to about where we were before. In general, hospitalizations are down about 50% from the peak that we saw towards the end of August and first part of September. So we've seen about a 50% reduction. We've also seen substantially fewer people in the ICU. Remember, at one point we were seeing routinely about 500 people a day in intensive care units across the state. So our system and multiple systems all over the state are seeing fewer people that are in the hospital, fewer people that are in intensive care unit beds because of COVID-19, which is outstanding. But it hasn't gone away. There are 250 people in ICU beds with COVID-19 right now.
So, as an extension, even though she's asking about the flu, and this reporter is saying, what do you think the flu season is going to look like this year compared to next year? But are you concerned for hospitals considering the pandemic is still not over, as your numbers report, and flu numbers are already meeting last year's peak?
Yeah, so the question is really about what could be the potential impact if we have a bad influenza season this year, the flu, if we see a lot of cases. Because remember, every year in the United States, influenza kills anywhere between, the most typical numbers are reported between 20 and 60,000 people. Nowhere close to what COVID killed. Nowhere close. But people do get sick. Some do end up in the hospital. Some do end up in the ICU. Kids are more vulnerable to some of the complications. Flu in pregnancy is not good. And so we do have concerns about whether we will see a worse flu season this year. We saw almost no cases last year, incredibly low cases of influenza last year, which we attributed to the fact that people were wearing masks, they were staying physically separated, social distancing, they were avoiding indoor events where the flu likes to spread. The flu spreads the same way that the COVID-19 virus does. So, yes, we do have a concern. COVID's not gone yet. And we do still have quite a few people in the hospital with COVID. And if we saw a big outbreak of influenza, it could, make it very, very difficult for the hospitals again. In Oklahoma, the most common month for outbreaks of influenza, for the biggest numbers, typically is January. But sometimes it happens earlier in December. Sometimes it happens later in February. So that's why now's the time to go out and get the flu shot, get the flu vaccine. Kids 6 months of age and older, everybody can get the flu vaccine, and it could substantially reduce complications of influenza.
Okay, Dana at the Oklahoman is asking, since we have heard from healthcare workers and seen some data that more younger, healthy people were being hospitalized and dying during the Delta wave than in previous waves, why is that? And is there something about Delta that affects younger, healthier people more?
Yeah, so it's a great question about Delta variant. So the graphic that I provided that talks about the risk of age and complications, that's cumulative data from the start of the pandemic, which included the original virus and then what's happened over the past couple of months, 3 months now, with the Delta variant. Delta variant did hospitalize more young people. If you were infected with the Delta variant, you were about twice as likely to be hospitalized as you were if you got the original virus, that what we call the wild type virus that came out of China. So definitely more virulent across the board, increased your risk of hospitalization. Second, the elderly were much, much better about being vaccinated in Oklahoma and across the country. And so we attribute some of the reduction in the number of cases in the elderly to the fact that they went out and sought the vaccine, and vaccination rates were much higher. I looked at Oklahoma County data the other day, and I think we're approaching 85% in the elderly population have had the vaccine. So it did seem to preferentially infect younger people, partly because they had lower vaccination rates, are more mobile, more social, and get out into settings. But let there be no doubt, the Delta variant was more contagious, spread easier, and if you were infected with the Delta variant, you had about a double the chance of being hospitalized compared to being infected with the original wild type virus.
Okay, when you were talking about the vaccine EUA for children coming up,
EUA, Emergency Use Authorization, yeah.
Are they looking at still like around November 4th, the first week of November, they think?
Yeah, it's my understanding that FDA now has their team of scientists going through the data for the vaccine, for the Pfizer vaccine specifically for ages 5 through 11. And they're going through the data to both look at efficacy data and safety data. Remember, Pfizer applied for, it's my understanding, that the dose would be 1/3 of the adult dose. So it's a smaller dose, so they want to see in that data set that the vaccine was effective at preventing COVID and that it was safe without complications. And so that's the process that's ongoing now. Once their scientists finish reviewing the data, they'll provide it to their advisory committee, who will then ultimately decide whether or not to make the recommendation for 5 to 11-year-olds for the emergency use authorization. And then that recommendation would go to the Centers for Disease Control, to the advisory committee on immunization practices, to make a recommendation about whether or not to authorize the use of the vaccine for kids. So once FDA advisory meets, that process will go very quickly. But right now they're in the data analysis stage. So I think 1st of November is, not unrealistic at this point.
So the dosage is where I was going next with the questions. So, are they talking again that it will be a 2-shot sequence, or?
That's my understanding, that it will be for kids a 2-shot sequence, 3 weeks apart, but it'll be a 1/3 of the adult dose of the vaccine.
So what would that, how promising then does that make it as we're going into the holiday season, that kids and families spend more time together this year and maybe be more safe?
Yeah, so we know that case counts are coming way down, and I really am hopeful that we can have reasonably normal holiday season this year. Kids represent a significant proportion of the population of Oklahoma, and so the more of them that we can get vaccinated, we'll see less spread of COVID-19. It's definitely spread in the classroom. Definitely, we know that. Again, across the board, cases are coming down. There are a lot of people who have already been infected that have some natural immunity. There are a lot more people that have been vaccinated. I truly am hopeful that we can have a reasonably normal holiday season, particularly with family, when you know you're around other people who are vaccinated.
Excellent. That is all I have. Anything you want to add?
Nothing else. Get your flu shot too.